Thank you so much. Good morning, everyone. Thank you so much for having me here today. My name is Aki Tsuchiyagaito. I am an associate investigator at the Laureate Institute for Brain Research, and I'm working closely together with Masaya. I have no disclosures. Let me start with a small story. Whenever I travel internationally, I enjoy trying something new food. Have you ever wondered how people figured out how to eat fugu, pufferfish? I bet first couple of people tried and they couldn't survive, unfortunately. But later on, people tried to eat it because it's delicious, and finally somebody figured out how to eat pufferfish safely. So this is a trial and error, and I feel like we are facing the same situation as the neurofeedback researchers. I believe that the true heroes are not the first one or the second one who tried pufferfish and sacrificed their life, but it is the people who tried, keep pushing, keep investigating, and finally made it safe. They are the true hero, right? And here we go. Oops. Okay, so today I'm gonna talk about connectivity-based real-time fMRI neurofeedback, and I also briefly mentioned about the ROI-based real-time fMRI neurofeedback for mood and anxiety disorders. In general, when we start real-time fMRI neurofeedback study, we have 3 steps. The first step is to identify the target. And the second step is to set up the real-time fMRI neurofeedback system, which Masaya explained in details in the previous session. And the third step, this is the stage we finally start recruiting participants to check if the target brain circuit or brain region is actually modifiable or not. At this stage, we are going to ask question, can participant actually modulate the circuit or brain region? And we are going to ask a question, will modified circuit lead to expected clinical outcomes? For my connectivity-based real-time fMRI neurofeedback study, we decided to target PCC and RTPJ because we found that hyperconnectivity between PCC and RTPJ was correlated with the trait rumination score. So we aimed to reduce this functional connectivity using the real-time fMRI neurofeedback. This was the first step. And for the second step, we decided to use 2 time point method, which originally proposed by Dr. Ramat, and details are explained in this published paper. But basically, this is the extreme case of the sliding window approach. We only focus on the 2 time point, which is t-1 and t. And briefly, I'm going to explain what we did. When the activity from the 2 ROIs move toward the same direction, we can assume that the functional connectivity was coupled. On the other hand, when 2 ROIs move towards an opposite direction, we can assume that the functional connectivity was decoupled or desynchronized. So this is a simple way to present the feedback for the participant because it can give us the binary feedback, positive feedback or no feedback. But this has a cons because we cannot present any information related to the strength of the functional connectivity. But we decided to go with this way because we did a simulation analysis, and we found out that two-time point method is good enough to have the correlation between the real-time feedback and offline connectivity analysis, and also it will avoid the contamination from the head motion and the physiological noise. And we did a clinical trials at the third step. The first aim was to determine the effect of the active feedback on target brain functional connectivity and changes in the repetitive negative thinking, which is a rumination score. And the second aim is to see the association between the changes in the brain and changes in the repetitive negative thinking score. We recruited 43 MDD participants, and we randomly assigned them to active or sham feedback. For the first aim, we didn't see any significant group difference in target functional connectivity. But for the clinical outcome, we observed that repetitive negative thinking score significantly reduced in active group, but not in the sham group. However, we didn't see any association between the changes in the brain connectivity and the changes in the repetitive negative thinking, which made us puzzled because now we cannot explain why we observed symptom reduction. So we did a post hoc analysis focusing on the mental strategies they used in the scanner. Subject reported 3 different types of the mental strategies to reduce their repetitive negative thinking and increase the positive feedback. They reported that they used reappraisal, positive thoughts, and distraction. And there is no group difference between active and sham in the use of the subtype of the mental strategies. But we asked 2 additional questionnaires. The first one is the frequency of the strategy use. How often did they use those mental strategies in their daily life before and after they experienced neurofeedback? By the way, they came back 1 week after the neurofeedback training. And the second question is the efficacy of the strategies. We asked how helpful those mental strategies were in their daily life before and after they experienced neurofeedback training. And only for the active group, they reported greater scores for both items, but not in the sham group. We also checked the connectivity and association between the connectivity changes and the use of the strategies, and we found that if the person was successful with reducing the functional connectivity, then most likely they reported that the mental strategy they identified in the scanner was helpful in their daily life, which is encouraging, and that made me think that the neurofeedback is not purely a device-based intervention, but more like neuroscience-based psychobehavioral intervention. Another study we did was the ROI-based real-time fMRI neurofeedback led by Dr. Neuroanatomically, and he combined with the mindfulness training like Sampras going to present later. And we extracted the signal from the PCC, and it is relatively simple compared with the connectivity-based neurofeedback, and we showed the signal change from PCC to the participant. And we asked them to downregulate the PCC to the level of the target bar. For this study, we recruited 83 teenagers, 40 were healthy control, and 43 were traumatized teenagers, early life adversity group. And only for the ELA group, we randomly assigned them to active or sham feedback. When we focus on the group difference between ELA and healthy control group, ELA group had difficulties in reducing PCC compared to healthy control group, which is not surprising. And when we focused on the active versus sham group in the ELA group, unfortunately, we saw that the sham did better than active neurofeedback. So we are at the third step, and we failed to show the validation of the modifiable circuit for the connectivity-based real-time fMRI neurofeedback and ROI-based real-time fMRI neurofeedback. But I thought that, especially for the connectivity-based real-time fMRI neurofeedback, there was one issue that we heavily relied on the resting state fMRI data to define the target. I think that the trait RNT and state RNT may not correlate with each other in MDD. In fact, we observed that the greater connectivity between anterior insular and other brain regions during the active engagement of the repetitive negative thinking compared to the resting state. And this is analyzed by my research assistant, Landon Edwards, and he did a lot of heavy lifting work. And he also checked the correlation between trait rumination and state rumination. And as you can see, of course, anxiety and depression highly correlated each other, and also within the trait rumination scale, it correlated with each other. But when you focus on the state rumination score, it is not associated with the trait rumination score. Another interesting finding is that younger adults with MDD had greater trait RNT, which is consistent with the prior studies, but they had a less state RNT during experimentally induced RNT conditions. So trait RNT and state RNT, we are measuring the different dimensions of the repetitive negative thinking. Now we are exploring the new avenue to combine the brain stimulation and real-time fMRI neurofeedback. We use the low-intensity focused ultrasound, and this study was led by Dr. Salvatore Guincen, and we targeted anterior remote of the internal capsule, which carries fibers from thalamus to prefrontal cortex and anterior cingulate cortex. And we did a crossover design study with 20 MDD participants. And for the resting state data analysis, we found that DIFU actually decreased the functional connectivity between thalamus to the gray matter regions reached by the stimulated white matter tract. It is beautiful to see how white matter tract we targeted and the changes in functional connectivity overlapping each other. We also observed that DIFU actually increased the joviality subscales in PANS compared with the sham. So, take-home messages. Depending on the study setting, neurofeedback could be considered more as a psychobehavioral intervention than a purely device-based approach. State matters because depending on the symptoms you are targeting, trait and state could be a different dimension. We are looking for the new avenue to combine the brain stimulation and the real-time fMRI neurofeedback because always the target engagement is the issue for the real-time fMRI neurofeedback. If we can be sure about the target engagement using the brain stimulation, then that can inform subsequent real-time fMRI neurofeedback intervention because I don't expect brain stimulation has a long-lasting effect, but real-time fMRI neurofeedback is the brain training and they can learn how to regulate their own brain activity, and it may lead to the long-lasting effect. Finally, we as neurofeedback researchers need a strategic approach and working group to accumulate evidence. For example, we didn't succeed with the PCC mindfulness meditation neurofeedback, but we can compare what was the difference between Sampra's study and our study. And I would like to thank to my late supervisor, Dr. Jerzy Bodylka, who laid the foundation for our neuroimaging setup. I also like to thank my lab members, mentors, collaborators, and funding sources. Thank you for your great attention.